Hello, friends. I guess you have seen that we started the YouTube channel. I haven't spent a lot of time on YouTube to really know what people from the medical field what they talk about. But what little I have seen, it seems like most um, pontificate about what they're interested in, what they can do. And I think maybe this channel should be a little different. This 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 channel is primarily about patients with chronic UTIs that have been unrecognized and obviously untreated. So I was thinking maybe doing something a little different, in that this is a condition where the patients know exactly what's wrong with them. They have undetected, untreated UTI that may have gone on for 3 weeks, 3 months, 3 years, or 30 years. So the problem is not so much the patient. It really, the problem boils down to the physicians who are not sitting down, listening to the patient, and helping the patient identify their problem and go on to a treatment that's successful. So I thought what we might do is we would want to talk to we really want to talk to patients. We really want to set examples, how to talk to patients with these problems. Again, these problems can be anything from recurrent UTIs, overactive bladder, painful bladder syndrome, interstitial cystitis, because that's really just a spectrum of the same condition, which is chronic bacterial cystitis. The so-called intraepithelial bacterial communities that live inside the urothelial lining that can cause pain, can cause irritation. Irritation of the bladder causes frequency and urgency, and many times this is associated with painful intercourse. So what I want to try to do is I want to try to get some feedback. I want to try to get some feedback so we can actually interview patients on this channel to try to set an example for doctors that realize that there's a problem that's not very well not very well identified. I mean, clearly we as doctors have patients that we know have a problem, but we can't put our finger exactly on what that problem is, how to diagnose it, and how to treat it. It really goes back to when I kind of stumbled upon the diagnosis, and really how all this got started was, I'd say 20 years ago, probably about 20 years ago. I had a patient. She was a middle-aged female patient, and I was probably maybe 3 to 5 years out of my residency, and she was miserable. She was miserable. She had severe frequency, she had severe urgency, she had 10 times getting up at night, pain, burning, just living a miserable existence. And I sat there and I told her, well, there's just nothing wrong with your bladder. I mean, look, This is your urinalysis. Your urinalysis is normal. There's no blood, there's no pus, the nitrites are negative. But nevertheless, there she was in the exam room, bawling her eyes out. And I remember that patient to this day because I wasn't there for her. I had empathy, but I knew I didn't know which way to go. I didn't know what to do. So I essentially told her that there was nothing wrong with her, when in fact there was something wrong with her. And then probably within the next year or two, I had one patient. I had a patient that had an infection. She came to the office. She has burning, frequency, urgency. Gave her a week of antibiotics. I don't remember what I used. Did a urine culture on her, and she improved, and she came back a month later. Same story. And I said, well, I'll show you. So I put her on 2 weeks of antibiotics. But I did a culture also. And when the culture came back, it was the same organism. The interesting thing about this organism is it had a very, very unusual resistance pattern. We know these bacteria by their name, but there are many of their cousins, and so we identify the cousins by their resistance patterns before DNA testing came along. And so I didn't think much about it. It was clearly the same organism. And that's real common. Most of them are E. coli. But the resistance pattern was the same. And I thought that was kind of weird. Because, of course, recurrent UTIs are just recurrent UTIs. It would never be from a persistent UTI. Well, in fact, I treated her for a couple of weeks, and she did really good for 4 or 6 weeks, and she came back. Same story. Got a culture, put her on antibiotics, and this time I noticed on the culture, same organism again. So I thought that's really odd. So I said, well, I'll show you this time. So I put her on a month of antibiotics. Did great for 3 months. Came back. Same story, same identical organism. Then it hit me. It hit me like a ton of bricks. It was like, oh my gosh, these are not new infections that these people are having. This is the same organism. This is a persistent infection that intermittently is exacerbating. So I said, well, I'll treat you even longer. So I treated her for 2 months, which at the time, my way of thinking was absurd that you would have to do that. Now, this is not, at night antibiotics to suppress. This is to kill. This is to cure, intent to cure an infection. She did really good for about 6 months. Came back. Same story, same organism, same resistance pattern. And so I started asking additional questions. And what I found was this patient thought she was well in between infections, but really, when you really drill down into it, the problem was she wasn't normal. She thought she was normal because she'd lived with it forever. But what she had was a baseline frequency and urgency and occasional urge incontinence, getting up 3 times at night, She had done that for so long she thought it was normal, when in fact that's not normal at all. It's very unusual for a patient with normal bladder function to get up more than twice at night. When they're getting up more than twice at night, there's something wrong, either at the brain level from anxiety, you know, a psychological reason, or her bladder is just not storing urine correctly. So I treated her aggressively for a while, and what we noticed was that as we treated her, her frequency and her urgency and her getting up at night just gradually improved over those several months. So then I began to apply this concept of persistent infection to other patients, and people that had urge incontinence that would normally be prescribed at that time, oxybutynin, Detrol, Sanctura, Toviaz. Those patients were all gradually improving, gradually resolving. And I got to where I didn't use those anticholinergics much. And I found also that a real typical symptom of a chronic cystitis patient was that you gave them, say, Detrol, and they come back in a month and they go, I was great. I was great for like 3 weeks, and all of a sudden, my symptoms are right back. And you would change their anticholinergic to something else like oxybutynin, Sanctura, Toviaz, and that was a really consistent story. Is that it would improve, but it would recur. The symptoms would improve with anticholinergics, but it would recur. And you would change them to something else, and they would get better, and then it would recur. And I found that didn't have a very durable response, and that was to me, that became a really typical sign of a patient with infection, that those medications were actually just masking the symptoms, not treating the problem. And then when you really get down to it, why do people have frequency and why do women have frequency and urgency? I mean, they used to talk about de novo bladder instability when I was a resident. Basically what that means is onset of frequency and urgency. Why did that happen? The bladder is really not a very smart organ. It really only knows to do two things. It knows to hurt and it knows to go. And if there's anything irritating the bladder, it's going to cause one or both of those symptoms. You can have pain without frequency and urgency, and you can have frequency and urgency without pain. Most of the time you're going to have both. But those are symptoms of bladder irritability. And in a female, it's going to be from a bacterial infection. In a male, those patients are going to be obstructed. They're going to have BPH. So my mantra that I always tried to teach people, whether they were residents or nurse practitioner students or whatever, was, it's really, bladder function is pretty simple. Men are obstructed and women are infected. And you're going to get 99% of the people right. If you go with that concept that men are obstructed, they need an alpha blocker. Women are infected, they need antibiotics. So at that point, or many, many years ago, I realized that we had stumbled onto something really big, and I was at a crossroads, really, of where I wanted to go with that. I have a family. We're all very close. we hunt and we fish together. And I had a decision to make whether, we needed to go with this concept of chronic bacterial cystitis or do what I like to do, which is be with my family. And I chose at that time to do that. So for 20 years, I've been treating patients the same way with aggressive, long-term antibiotics to eradicate this infection. What's happened in the past, I would say 7 to 8 years, I've really learned a lot more about it. And that really came about with DNA testing. Because we see people all the time that have women. We see women all the time that have pain, frequency, and urgency. They got a normal urinalysis. I mean, it's stone cold normal. There's no blood. There's no pus. There's nothing there. And those are the people that are told they have nothing wrong with them because they have a normal urinalysis. So after I experienced some of these patients getting better, I said, well, I started treating them the same way, whether they had a normal urinalysis or an abnormal urinalysis, normal culture, negative culture, treated them all the same way, and they respond. So what that led me to come up with really was these tests are only helpful if they're positive. I'm talking about urinalysis and urine culture. A urine culture is a fantastic test when it's positive. Unfortunately, it's a terrible test when it's negative. You can have a florid infection in the face of a negative urine culture. And there's many reasons for that. You can have patients that have only an intraepithelial infection and no bacteria in their urine. More likely what you have is a patient with an infection. They send a urine culture. The lab looks at the petri dish and goes, oh, there's 3 or 4 organisms over there on that plate. We'll throw that one in the trash. That's the most common cause of a negative urine culture. So the next thing that I wanted to talk about really is how we can help doctors. How can we help them identify and treat patients with this problem? And so I got to, there may be a role for patients that are coming in the future where, patients that have an appointment, maybe they would be willing to let their interview be done so we can put it on YouTube. We wouldn't have to show their face. We wouldn't have to use their name, but we could go through the interview process, how to evaluate a patient with chronic bacterial cystitis that has been told that they have overactive bladder, painful bladder syndrome, interstitial cystitis, and see if we can help some people. I think there's going to be some big things that happen with this condition over the next year. We have a lot of data that's being assimilated right now, and our plan is to hopefully present that at the annual meeting of the AUA in Denver. So maybe you guys could give us some feedback. Are there people that are coming for appointments in the future that would be willing to, do their interview and evaluation on video so other doctors could look? Are there people that I've seen in the past that would like to do, would consider doing their follow-up interview on video so other people can see responses? So that's really all I have today. I'm on call. I'm exhausted. I'm between surgeries right now. It's Sunday. I look forward to hearing what you guys have to say.